Hey everybody, welcome to this week's video where we're going to be talking all about the NICU. You may recognize a new face here, and that is because I have brought in a friend to help me because I have never worked in the NICU. So I'm going to let him introduce himself in just a minute, but basically the point of today's video is just to talk about the NICU, things that if you have never been a NICU parent that you think everyone should just kind of know, things that if you are a NICU healthcare worker that you wish everyone kind of knew, and just kind of talk about it because I feel like it's such a niche little world. Do you agree that it's like its own little thing?
Yeah.
And unless you're shoved into it, and you're usually shoved into it shockingly, it's not like something you necessarily plan, then you know about it. But if not, you don't. So we're just going to talk about it. And so if anyone's going through anything with it, you can hopefully be a resource to just kind of be like, oh, I know about that. Or if your friend one day has a baby that's in the NICU, you can be a little bit more like just knowledgeable about it, which is always good. This video is sponsored by Water Wipes. And their whole campaign with this is just to raise awareness around it. They obviously make wipes that are like very, the purest brand out there so that you just can save those little baby booties. I know we used a lot of water wipes at the hospital I worked at with the tiny humans. So they're just raising awareness for it. All right. Would you like to take over, Josh, and introduce yourself?
Sure. So my name is Josh. I'm a registered nurse in a level 3 NICU in Central Florida. I've been working in the NICU for a little over a year now, and I love working with those tiny babies. I'm certified in the care of extremely low birth weight infants. So that's kind of like my favorite population. But I obviously care for babies anywhere from brand new to up to a year old. It's my absolute favorite thing in the world. So.
And this was your first nursing job, right?
Correct. Yeah.
Yeah. So, and we're going to do a whole nother interview with Josh talking all about how he got a job in the NICU as a new grad, what that's kind of been like, what he loves about it, NNP stuff and all that goodness. So don't worry, we will be back. I'm forcing him to do it essentially at this point. I just told him, I was like, hey, so this is great. Let's do another one. Okay.
Yeah.
So what we're going to be doing is basically, I asked you guys on Instagram for a ton of just different things that you wish people knew. So this is going to come from nurses who work in the NICU. This is going to come from parents. This is going to come from healthcare workers who have had kids in the NICU. And just kind of, Josh is here to just kind of give any insight on his part of, because I worked with babies with cardiac conditions, but they were, at least they were almost fully baked usually by the time they came to us. And I know they're not, someone had even said that NICU babies aren't tiny babies. They're like their whole own thing, which makes sense because everything is so different because they are supposed to still be cooking in the oven, but they're just not there yet. Have you found that to be pretty true with like when the babies are like super duper, like physiology wise, things are even changing?
Yeah, especially when you think about things like the lungs and the skin and the brain. So when they're born extremely premature, so I'm talking anywhere from like 22 to 28 weeks, you can see some very drastic differences compared to babies who are born, 37 weeks and older. So there's definitely different policies and procedures in place for caring for those little ones. So
yeah, what would be some of the biggest differences you think that parents could like expect if they had a 23 weeker that would be different in terms of like skin? Like, can you hold them? Can you touch them? Like, what is going on with that?
yeah, so you can definitely still hold and touch if they don't have umbilical lines. So a lot of times with our preemie babies, we call them tiny babies. So any babies born less than 25 weeks, we call them tiny babies. And if they have umbilical lines, we don't allow holding just because there's a lot of risks that come with that. Infection, it could be pulled out, things like that. And then the ventilation. So typically with those really tiny ones, we use a specific type of ventilation in place. We call it jet ventilation. And that means that they have to be intubated. So a lot of times these tiny babies, their lungs have not developed. So they need that extra support for their respiration. And that's really the biggest things, I think, with baby. You mentioned cardiac. When you compare babies to adults, we look at respiratory is the main issue that they typically have versus like adults, if they go into cardiac or if they need CPR, it's a cardiac issue. So, but yeah, you can absolutely still touch. The skin is very, very thin. So they're at risk for, impaired skin integrity. So tears, really, they bruise really easily. And then one of the things that a lot of people don't realize is insensible water loss. And
Oh
so
yeah.
they lose a lot of water through their skin because their skin is so thin. And so we have to put them on humidity inside the isolettes. We have to really pay attention to how much urine output they're putting out, so that we can replace those fluids.
Is that, I've seen babies in the NICU with like plastic bags almost around them. Is that what that's
Mhm.
kind of for, is to retain the humidity
The
or just
humidity
keep
and
them
the
warm and keep them
Yeah, both.
warm?
So humidity and heat, when they're first born.
Mm-hmm.
So down in the delivery room, when those tiny babies come out, we'll put them in a plastic bag, for both humidity, yep, to retain that water, and then also to keep them warm because they're unable to regulate their own temperature. And
Yeah.
that's more of a neurological thing, as well, versus, an older baby. Like you said, a baby who's fully baked. So
Yeah. Anything. Oh, and someone else kind of along those lines was saying that they were shocked by how long they had to actually wait to hold their baby. Do you find
Mhm.
that that's kind of like, is there a standard benchmark of like, oh, when you kind of hit this point, or is it very dependent on like how the baby is doing? And then it could probably, I would imagine, even change because I know they change their status so often.
Right. So for us, at least what I've experienced is it really depends on what's going on with the baby. Like I said, if they have umbilical lines, they can't be held at that time. And for us, umbilical lines last anywhere from 3 to 5 days, and then we can pull them out. If they're intubated, they can be held. It's just very nerve wracking for us as
Mm-hmm.
healthcare professionals because they're so tiny. So even the smallest movement of the endotracheal tube could be the difference between ventilating and not ventilating. And
Mm-hmm.
so it's very, very sketchy.
Yeah.
but
Yeah.
but I definitely understand the importance. There's a lot of benefits to parents holding that skin to skin contact. Um, it promotes bonding. It helps with pain. It helps with stress. It helps with neurological development. It helps with temperature regulation. So there's a ton of benefits. And then for mom, it helps with breast milk production. So
Mm-hmm.
um, it's very, very important, and we try to encourage it as much as possible, but we also have to kind of manage the baby too. So if they were just recently extubated, we usually hold off on holding just to see how they adjust,
Mm-hmm.
because sometimes it takes them a day or two. If they're under phototherapy lights, then we try to limit holding because we want them under the lights as much as possible.
Mm-hmm.
So it really does depend on the baby and the situation that's going on. So
Yeah. Oh, and that is hard. We did a ton of phototherapy on our floor, and that was just hard
mhm.
because you had those, and these were like otherwise healthy newborns, and they just want to be
Right.
held. Instead, they were like
Yeah.
bacon under there with their like,
Yeah.
we called it their sun tanning bed, but that's not where
Yeah.
you want your newborn to be. You want them to
No.
be right here.
Yeah.
You mentioned breastfeeding, and like I know having the baby like skin to skin, that'll help stimulate any kind of milk supply. So this, I had a lot of questions that were on both sides of it. Some people felt that the whole experience was just like really difficult. Obviously, that's not the way you expect to bring your baby home or the
Right.
experience you expect. And like we had said before, like a lot of times it's shocking. It's not, some people plan for it if it's, a high
Mhm.
risk delivery, but a lot of people don't. And so some people felt like they were really pushed to like pump and do all the breastfeeding stuff and they didn't want to.
Mhm.
So I guess part of it we could talk about, like from your standpoint, like what is, the importance kind of breast milk in these tiny babies. And then two, like the other side of it, a lot of people expressed frustration of they really wanted to breastfeed, but they weren't allowed to. And
Yeah.
then, so they kind of felt like, torn in the middle of sometimes, some people felt like it was very anti-breastfeeding and some people thought it was very like, if you don't do this, like, what are you doing?
Right. Right.
Do you have any
I
kind
definitely
of insight?
I can definitely understand that. There are, what do you call them? They're like baby friendly hospitals or something like that. I
Yeah.
know I
Yeah.
know we're baby friendly. So what that means is we promote breastfeeding. Breastfeeding is
Mm-hmm.
definitely important. Breast milk, in particular, it helps to reduce the risk of neck or necrotizing enterocolitis, which
Mm-hmm.
is an infection in the intestines. Um, and so, breast milk is very important for that. And so we definitely want to promote breastfeeding, but I think it's also important to respect, the parents' wishes. And if they don't want to breastfeed and they don't want to do that, then that's fine too. I mean, if they don't want to pump, and that's entirely up to them. At least that's my take on it. For those that really want to breastfeed and they're not able to, there's, several different reasons why we may not allow the breastfeeding. One of them, if they are receiving any type of respiration support from CPAP, all the way up until intubation, they're obviously not going to be able to get a good latch and breastfeed. So it's not that we don't want them to, or that, parents are discouraged from it. It's just that at that point in time, it's not best for the baby. So, and then really babies don't start to develop a suck until around 30 weeks.
Oh,
so I
that's
think it's all the way
interesting. I
up.
didn't know that. Yeah.
Yeah. So around 30 to 32 weeks is when we really start looking at whether or not they're able to breastfeed or bottle feed. And so until then, they're going to receive their nutrition either through intravenous fluids or through gavage feeding through an orogastric tube or nasogastric tube. But it's not that it's discouraged, it's that we have to take into account the baby's condition and whether or not they're able to. So just from a neurological standpoint, they can't until about 30, 32 weeks. And then even then it could be a struggle. They're going to start a little bit at a time because just neurologically, they haven't developed their suck yet, the swallow, it all has, and the breathing. And so it all has to be coordinated. And so it takes a little bit of time sometimes. And
my fully baked daughter could not figure that out for months. It was an intense. Do you find that a lot of people, like babies will, even if, if say they're born like in the 20s, do you see them going on and having like successful breastfeeding experiences once they gain that, or is that less likely in what you've seen?
I have seen some who were born early, even tiny babies who have had success. It really, again, it depends on kind of their neurological history. The tiny babies, the vasculature in their head is very, very fragile. I mean, their vasculature in general is very, very fragile. And so it's not uncommon for them to have brain bleeds. Now, all of them are not severe, but sometimes they can be. And so that will affect some neurological outcomes down the line, and some neuromuscular outcomes too. But I have seen it. I have seen, tiny babies do really, really well and breastfeed. And I took care of a tiny baby who she should be going home here soon. But she, I believe, is breastfeeding or bottle feeding now, and she's doing really well. So
that's awesome.
It does happen. Yeah. And that, it's great to see. I love seeing that.
Yeah. Okay. So it sounds mostly like it's never, that the person, like, cause a lot of people are like, oh, the nurses in the hospital just want to make it easier so that they can just, stick it through the tube. It sounds like it's definitely much more, this is what, like, in a hierarchy of what baby needs right now, baby needs food without any work. And I know before we were talking about too, like some conditions like eating for a baby, we always used to call it on our cardiac for like running a marathon. Like that is the hardest thing other than maybe pooping that like they will do. Yeah. And it takes so much energy. And so you don't want to spend more energy than you get. And so like, we don't think of it as anything, but that can just like wipe a little one out.
Yeah. Especially if they're bottle feeding or breastfeeding for too long, if their calorie expenditure is greater than the calorie intake, then we could be delaying growth. And then that's going to increase their time in the NICU. So we definitely have growth goals that we see and that we're trying to obtain. And so, that's definitely another aspect that we have to take into account.
Yeah. Oh, I remember that. And we would have like a 20-minute limit for our cart babies. And so you had to be done with your feed, and then we would weigh them and see how much extra they were going to need. And that caused a lot of frustration. They're like, it might just take longer. We're like, I know, but it can't, it just can't in this case. So you were saying you had a tiny baby. Do you get to be their primary nurse a lot? Like, could parents expect to kind of have sort of the same nursing staff, or do you think that varies by NICU?
I know that at our NICU, we do have primary nurses, especially for tiny babies. We definitely encourage that just because their stay is going to be very long. So typically our babies don't discharge until around their due date if they're doing really well. And so you can definitely expect to have primary nurses for the tiny babies, and sometimes for ones that we know are going to be there for a while, even though they're a little bit older, whether because they have congenital malformations or whatever the case may be. I've been asked to primary a few different babies, a couple of tinies, and ones that weren't technically tiny babies. They were like 25 weekers, but still really, really little.
Yeah,
exactly. So, and I love it. Like I said, that's my favorite population. So I love working with them. I love educating parents
Yeah.
on, on caring for them, because they will come in the isolate and perform
Mm.
care. And so I love that aspect of it, because I
Yeah.
realize that these parents feel very vulnerable and helpless
Mhm.
and scared. And so if I can help them kind of get a little bit of control over something and provide, some care to to their own babies, it feels good.
Yeah. And I think that brings up a good point that I think, at least from my understanding in NICUs, a lot people brought up that care is very scheduled. And so usually there's what like
Mhm.
people call cares. And so, at least in my experience, you've kind of gone in and whenever you mess with a baby, like babies that, if they're 23 weeks, they're not supposed to be really being messed with a ton. So you kind of go in
Right.
and clump it all together. And it's not
Mhm.
like, oh, I'm lazy, I want to get this done. Because a few people were like, oh, they just only seem to pay attention to my baby once every 2 or 3 hours.
Mhm.
When I think it's probably, is that what you would clump under like your care hour or your cares
Yeah.
tasks? Mm-hmm.
So we do our hands-on, we call them hands-on care
Mm-hmm.
every 6 hours. So that's like a full assessment of the baby. Um, and then, and even our second hands-on, which is halfway through our shift, is kind of an abbreviated version.
Mm-hmm.
And then they're usually on a feeding schedule of every 3 hours.
Mm-hmm.
And for the tiny babies, we try to minimize stimulation. Like you said, they're not really supposed to be messed with, because this is a lot of stimulation. Thinking about lights and noises,
Mm-hmm.
movement, a lot of people touching them, um, on top of the ventilation, because they're probably intubated. And so it's a lot of stimulation for their little brains. And that actually delays their brain development the more that they're stimulated. So, they're supposed to be in a quiet, dark
Mm-hmm.
place.
Yeah. Yeah.
And
Yeah.
so it's not that we're ignoring them. It's just that we want to minimize that stimulation. So we try to go into the isolate as little as possible. Um, and I know that parents want to be in there and they want to touch them and they
Mm-hmm.
want to, they want to care for them. And I get that. I really do. But we also have to make sure that, we keep the babies safe and we
Mm-hmm.
keep them growing. And so like I will only go in and I'll just check placement of their oral gastric tube, and then I'll feed them. And that's it.
Yeah.
Like I'll put the syringe on the pump and I feed them, and then I don't do anything else, because I don't want to move them. I don't want to,
Mm-hmm.
jostle them around for a number of different reasons. So that's definitely something that we have to take into account. And when it comes to their neurological development, if they were born at 22 weeks, even when they reach 40 weeks, their brain is still not as developed as a term baby.
Mm-hmm.
And so they're going to be a little bit delayed in their growth as it is, even if we do everything
Mm-hmm.
perfect. So,
Yeah,
you
they
know,
have 2 years, I think, to catch up, is from
yeah,
what, at least when I'm seeing, because I see them on the outpatient side when they're a little older. And so we
right.
give them until they're 2 to really
Yeah,
usually around 2, those kids are usually running par and par with their
yeah, yeah.
other
So it
fully
takes time.
baked.
It takes time.
Yeah.
Yeah.
What would you describe? A lot of people commented that they were surprised by the environment of the NICU. How would you kind of describe the environment? Like some people thought it was much louder than they thought, and other people thought it was like some dimly lit den of like, which you talked about, like it needs to be like
Yeah.
we're kind of trying to simulate a womb. So like that makes
Right.
sense.
Yeah. So for older babies, we'll cycle lighting. So we'll open up the curtains if our rooms have windows, so that they can have a little bit of daylight. For the tiny babies, we'll cover the isolates and keep the room as dark as possible, so that we minimize that stimulation. As far as the noise goes, sometimes it can be loud. We have X-ray machines coming around, and they really do sound like little race cars on a track. Those mobile
They do.
X-rays. You can always hear them coming down the hall. And sometimes we have other stuff going on. We have bedside procedures, and so things can get a little bit rowdy in that regard. And sometimes there are overhead announcements, or there are alarms, or whatever the case may be. So it may be a little bit louder than people expect. It's not going to be super super quiet, but we try to keep it as quiet as possible for them, when we can. But I know I figure at night shift is probably much more quiet and much darker. I know when I come in the morning, like all the lights are off.
Yeah.
I don't know how you stay awake, but
yeah. Oh, I know. And it like, I really liked working night shift more than day shift. And that's how it was. And then you'd come in and everyone was like turning the lights on. You're like, oh my gosh, like this place is terrible. Like, like, oh, and they
Yeah.
would just, you knew they were there and you were like, oh my
Yeah.
gosh, like my retinas. I know that. What would be, so since you're obviously trying to like not bother, like low stimulation for these babies so that they're going to be able to kind of just develop how they need to, what would be some things that you would recommend for parents to do if they just feel like, oh my gosh, I'm just like, I need to do something for this baby, that would be helpful to kind of, just feel involved, when I'm sure in those situations you just feel so helpless and like a bystander a lot of the time.
Right. So we encourage the parents to read to the babies, or we also do some music therapy sometimes. So we've had moms record their voices singing a song, and we'll play it for the babies. But every baby gets a book. We have a developmental care team that comes around, and they have books for the babies, and so you can read to the babies. We have websites that you can go on your phone and pull up books so you can read to them. Hands-on time. So we encourage parents to come to hands-on time so that we can, teach them on how to care for the baby, and they can get in there and touch them and provide care. That's also the time that we usually encourage them to come so we can do skin to skin, or if they want to hold. So since we're already in there, right afterwards, we'll do skin to skin. We try not to do it, at random times, because we want to minimize stimulation, like you said. And then just, not always going in and out of the isolette. So we think that we're being as quiet as we can, but it actually makes a lot of noise for them. It's if you think of it like you put a bucket over your head and then you like bang on it a little bit, or you make some noise in there, it just kind of reverberates off the walls inside the isolette. So, but yeah, we definitely encourage parents to come when they can, and even just being at the bedside and just, sitting there with them, I feel like gives them a little bit more peace.
Do most places I know at our hospital, a lot of parents would at least do blankets, and that was like literally all they could do. So I had a lot of people who and they would change out the blanket every day that was kind of going over the end. Does yours let you do that, where you can kind of personalize some kind of thing to go over the isolette, or is it pretty regulated?
So they can bring in their own blankets. They can bring in their own clothes for the babies, hats, things like that. We just have to make sure that they're washed before they get brought in. But we've had parents who, like, their mothers knitted some personalized hats for them, stuff like that. So yeah, that is definitely encouraged. We don't always have them, but sometimes we have like these little, they remind me of like little octopus, or butterflies, and we'll send them home with mom, and then they can put it on their skin and bring it back, and so that it has their scent on it, and we'll put that on the babies, or near them, so they can smell it, and that helps with the bonding as well. So we definitely encourage involvement, because it's tough when they have to leave them there, and it kind of impairs some of that bonding. And so we definitely encourage anything that can help with that bonding, and help them help the parents feel like they're contributing in some way.
Yeah. And that was something else that a lot of people brought up, was they feel bad leaving, especially in NICUs where like parents are technically allowed to room in, if it's all like, it's a private room and they're technically allowed to stay. Do you, and I didn't say anything to them because I figured we would talk with you. I know, like, I encouraged parents when we had people staying for like a long time, like go home, like kind of have your hours, like check in. I say like even stay until night shift gets here. So you like check in with the nurse and be like, I'm going to go, wherever. But like, you need to leave, you need to go outside of the hospital and like breathe air and like do your thing, and not feel bad that like, we don't see it as abandonment. Like, I see it as like you taking care of you. So I didn't know if you had any insight on that, because a lot of people were like, I don't want the nurses to think I'm abandoning my baby, but like I have to leave, like need to go to my other kids, or like, just take a shower at home, like something like that.
Yeah, no, we definitely encourage parents to perform self-care, because we've seen parents who won't leave the bedside, and you can see how physically and mentally exhausted they are. And so we definitely encourage them to go get something to eat, go home, take a shower. If they have other kids, go tend to your other kids. If they have to work, go to work and come back. Like, your baby will be here, and we're going to be taking care of them. So we definitely don't see it as abandonment. we realized that life exists outside the hospital.
Yeah,
And
this was not the plan. Like,
yeah, exactly.
yeah.
Right. Like you said, most people, I would say like 99% of people don't expect to end up in the NICU. So um, they definitely, so in the level 3 side, we don't allow rooming in.
Mhm.
If they're a complex patient who's about to be discharged, then we'll do rooming in for a couple of nights so that parents
Mhm.
can get used to caring for them.
Mhm.
But on the level 2 side, they will allow some rooming in at times. But yeah, so we definitely encourage them. We also have Ronald McDonald House, so they can apply for
Mhm.
that, and that's
Those are
just across
amazing.
the street.
Mhm.
Yeah, so that's just across the street from us. And so if they want to stay there for a little while, if they live far away, because we are a really large NICU, and we transport in a lot of babies,
Mhm.
um, and so sometimes the parents live 2 hours away, and that's a lot to be driving back and forth. So
Yeah.
Ronald McDonald House, I think, is very helpful for that. It
Oh my
allows them to
gosh,
stay
yeah.
close by. So, but yeah, we
Yeah.
definitely encourage, take some time for yourself. We get it. It's
Mhm.
it's exhausting. It's exhausting for us, and
Yeah.
we're not even the parents. So,
Yeah.
um,
Yeah. Yeah. And yeah, and hospitals are just, yeah, that vibe is not, you don't need to be in one
right,
all the time. And I was just
right.
like, ooh,
No.
ooh, no. Do you, I forget what I was going to say. There was a question that I was just thinking of. We'll come back to it. Well, how long do you usually think? A lot of people said that they were just completely, like, understandably shocked and overwhelmed in the beginning. And then by the end, they like didn't want to leave because it was like their
Mhm.
cocoon nest of like safety.
Yeah.
How long do you feel like that transition usually takes, in case parents are watching and they're in that initial, like, I'm terrified, like, to kind of get comfortable with it as much as you can get comfortable with this totally odd? Like, do you kind of see parents hitting like 2 weeks, 3 weeks, and then being like, oh, okay,
Yeah.
like I live here now? Like, that was kind of like
Yeah.
2 or 3 weeks was like when all of a sudden the parents started like walking around our unit, like they owned it. And you were like,
Mhm.
okay, like you have accepted us as your,
Yeah. Yeah. That seems to be a good amount of time. I think it's a little bit easier for babies who are a little bit bigger, and maybe they're
Mhm.
just there for a little bit of respiratory support. I feel like they adjust a little bit quicker. For the babies
Mhm.
who are more sick, I'll say, it takes a little bit longer, especially with the tinies. I know all the parents are afraid to touch the tinies,
Oh
and I
yeah, I would
totally get
be.
that.
Yeah.
I totally get that. I took care of a baby who was 345 grams.
Gosh.
345 grams. So super, super tiny. And so they were afraid about touching. And I'm like, it's okay. Like they're fragile, but they're not as fragile as you think they are.
Yeah.
It's okay to
Yeah.
touch them. We
Yeah.
touch them all the time.
Yeah. And
So,
if you think about
you
it
know,
too, yeah, like when they're in there, I mean, you're jabbing them out of your rib all the time. You're like,
right.
no, thank you. Like, get out
Yeah,
of here.
you feel them in there. So
Yeah. Yeah. They're not
yeah.
gentle. Yeah.
Yeah.
Um, do you think it's one of the other, we have two more and then we'll wrap up so we're not stealing your whole day. Do
No,
you
it's okay.
think it's fairly normal to anticipate kind of going 2 steps forward, 1 step backwards? A lot of people said that they were kind of unprepared for, they thought it was going to be more of like, okay, we got through those initial, like that initial week and things looked
Mhm.
good. And then it was not like up and up. It was more like
Yes.
all over.
Yes. So we kind of refer to that first week as like the honeymoon period.
Mhm.
A lot of times our babies do really, really well in the beginning. The first week or so, we'll start weaning on their O's and on their oxygen saturation. Um, and we will see improvements in the ventilation settings. And then all of a sudden, they start kind of decompensating. And so
Mhm.
that's very, very normal, especially for the little ones, less like 28 weeks or less. Uh, and so, yeah, it's sometimes it's a roller coaster. Sometimes it's smooth and it's,
Mhm.
that linear progression. But a lot of times it's not. A lot of times there's different things that come up. Sometimes we'll end up with babies who we switch support, and, we extubate them, and now they're on NIV-NAVA or bubble CPAP, and we get air in their belly. So their belly gets up bigger, and then they can't tolerate feed, so they're spitting up, and so we have to adjust
Mhm.
that, and now they're back on fluids when they weren't on fluids before. So it sometimes it seems like we're going backwards, but it's constantly shifting. We're
Yeah.
constantly shifting depending on how they're progressing and, what's going on. So it's always a puzzle that we're trying to piece together. So
Yeah. And they're so like, I only worked with babies that were, like I said, pretty much like full term. They were so sensitive to even the
Mhm.
tiniest little change. Whereas an adult, you have so much more compensatory like mechanisms where it's like,
Right.
meh, if a little bit
Right.
goes wrong, it's fine. But like these babies, I felt like one tiny thing and you're like, oh, wow,
Yeah.
this, like so many things happened from the
Yeah.
fact that like your IV was in the wrong spot for 3 minutes. Like,
Yeah.
holy cow,
Yeah.
like what on earth?
Yeah.
Um, and then, so the last thing was a lot of people. So I have like most obviously my channel is like healthcare people. And so they were just
Mhm.
kind of saying that it was hard a lot of the times as healthcare people in terms of communication, everyone felt like they were like communicating with them directly, even though they were like pharmacists for like adults
Mhm.
or, like a nurse in the ER. And just kind of like, they were like, I have no idea. And that kind of embracing like that's okay. And so do you
Mhm.
feel like you see that a lot where it's like healthcare people, but they just have no idea and that's normal? Cause I felt like that was the big thing of just like, is that I think
Yeah.
everyone felt bad that like they didn't know, you know what I mean? Like, oh,
Mhm.
I should know this because I'm, whatever. But like, I would have no
Yeah.
idea if my kid was in the NICU. I would be like, oh,
Yeah.
just don't even,
I
I
think
don't even.
we've seen kind of both. Seen kind of both sides where we have parents who are nurses or other healthcare professionals, and they obviously sometimes we speak to them in our lingo, which is
Mm-hmm,
very different in the NICU than other
mm-hmm,
places, I'm sure. And so I think it's hard because we realize they're healthcare professionals. We communicate with them that way, and they don't always understand. And so
mm-hmm,
sometimes we have to take a step back and kind of break it down for them and
mm-hmm,
try to treat them. I try to treat everybody the same,
mm-hmm,
regardless of what their background is, just because, like you said, you come from a different field, you're not going to necessarily know what that
mm-hmm.
means. Um, and then we've also had people who felt like they knew better
Oh,
than the
I'm sure.
neonatologists and
I'm
the
sure.
nurses who are on the floor. So we've had both sides,
Yeah.
and I feel like it's definitely easier to work with people who are less understanding than those
Mm-hmm.
who try to come in and take control of everything, for sure. But
Do your job for you.
um,
Yeah.
yeah, yeah. And so it's but yeah, I try to educate everybody the same. I think one of the things that's very interesting. So one of the babies I primaried, mom was a neonatal and pediatric transport nurse
Oh.
um, for a different hospital, but so she had a pretty good understanding of what was going on overall. But dad's an assistant principal at a high
Uh-huh.
school, so he has no idea what's
Mm-hmm.
going on. And I know that I think sometimes they felt like we weren't speaking to dad and weren't
Mm-hmm.
explaining things to dad. And so being a male in the NICU and being a father myself, like I tried to
Mm-hmm.
speak to both of them and explain
Mm-hmm.
things to both of them. I think, and it's not uncommon. I've heard other nurses say, they're like, oh, I always forget to speak to dad. And it's like, they're,
Mm-hmm.
they're so focused on mom. And I'm like, well, dad's
Mm-hmm.
here too. Like he's
Yeah.
part of this family and he's going to be
Yeah.
holding and he's going to want to do skin to skin
Yeah.
and he's going to want to
Yeah.
provide care. So I always try to involve both parents as best
That's
as I can.
awesome. That was another
Yeah.
really, a couple people said that on both sides, that when they were the medical person and everything was explained to them and not their spouse or
Mm-hmm.
their partner, because they would only speak it in like medicalese and then kind of expected them to translate that into like, what does that actually mean? And you're kind of
Yeah.
already, I would assume, at the end of your rope, especially there in the beginning when you're like, I don't want to like explain it to you. Like
Yeah.
I know I would get frustrated if I had to do that. Like I would be irrationally annoyed with my husband who had absolutely
Yeah.
nothing to do with this choice. Um, and so then kind of, yeah, like explaining it I kind of go with you where I explain it at like the more broken down version. And
Mm-hmm.
then if you like, I let the other person, I'm like, you translate that into whatever like medical jargon
Yeah.
you want, but like, we're going to do it once here.
Yeah.
And then the dads, like a lot of dads wrote in and we're like, yeah, like I felt like everything was about like my wife or my girlfriend or like, and I was
Yeah.
kind of like this, oh, like, or even like, oh my gosh, like dad's here, like this
Yeah.
big thing, where it was like the expectation that of course mom's going to be there and she's going to be doing all
Yeah.
of this when like here we have dad and it's like, oh, like
Yeah.
this let's just make this normal, not like,
Right.
hooray,
Right.
you're here. Like,
Yeah. And it's funny because most of the time dads come up from the deliveries. It's dad who
yeah,
obviously mom's not
yeah,
accompanying the baby. She's still downstairs. So,
yeah,
um, so I feel like that's when like dad gets paid most attention to. And then after that, it's kind of, sometimes he's not as included as much, but you know, I think overall we do a pretty good job, but sometimes, yeah, dad's definitely missed.
yeah. Oh my gosh. That's like one of my weird, my pet peeves in life. That's one of my, when I change the world, like whenever on all of our daycare paperworks, it's like, call him first, because when I was working in the office, like I was not available, and he
Yeah.
works with computers. So like he is available for a phone call, and they would never call me. They would always call me and not him. I'm like, he is
Oh yeah.
literally the first contact. And they're like, but your mom. I'm like, and he's their dad. Like he
Yeah.
is the one who is going to be coming and picking them up. Like, I don't know what you want me
Yeah.
to do. Or when I was working on the floor, I was like, this is annoying. Okay. Anything that we didn't really talk about that you would like just people to know in general about the NICU?
In general about the NICU.
That you
I
see like
think
either
that
surprising people the most or
surprising people. I think one of the biggest things that, and we need to look at it from our side too more often, because we're so focused on just providing care for the baby, like making sure the baby gets what they need. But a lot of parents are freaked out about scalp IVs.
oh yeah.
So that's not really something you see in adults, obviously.
Mhm.
But for babies, we use scalp IVs quite often. And so sometimes when they have hair, we'll shave their hair.
Mhm.
And sometimes parents are not so happy about that. And
Yeah.
I get it. I get it. We had to do it for this baby who she had pulmonary atresia. So she wasn't able to get, blood from her heart
Mhm.
to her lungs.
Mhm.
And the only way it was able to happen was through her patent ductus arteriosus, which is fetal circulation. So we had to keep that vessel open, and we had to get her, prostaglandin, so a very specific medication. And we were struggling to get access. And
Yeah,
so
because those
we
babies
shaved
do
her
not
head.
have good access, just in general.
No,
I have
no,
found. Yeah.
cardiac babies don't, is what we
No, they do
found.
not.
So yeah, they shaved her head to try to get it, and they couldn't get it. And yeah, dad was not happy. And I was like, I get it, I understand. And I was caring for her that day. And I was like, I understand, but we got to make sure it's either this or she passes away, because she needs it to stay
Yeah,
alive.
yeah,
And
yeah.
so, her hair will grow back,
Hmm.
but you
Yeah,
can't bring her if that
yeah.
closes. So it's kind of one of those situations. Scalp IVs are normal. It doesn't go into the brain.
No,
A
it
lot
just
of parents
looks,
think that it
yeah,
does.
yeah,
It doesn't go into
yeah.
the brain. It's on the surface. It's not even inside the bone. It's on the outside of the bone. So
Oh,
I
yeah.
know it doesn't look good, but sometimes it's all we can get. And at the end of the day, the baby needs the medication or the fluids. So we have to do something. But
And it doesn't seem to bother them at all. I know those were always the
no,
ones
no,
when I knew
yeah,
parents were coming back and we had to place one there. I was like, I'm just
yeah,
coming. Like you tried to catch them
yeah,
so hard before they went in the room. You're
yeah,
like, just quick, like things are
yeah.
going to look different than you're
It
expecting.
and in some ways it's better, because when it's on their hands, because we do a lot of hands or
Hmm.
feet or in their arms, they're moving around and they go
Yeah.
bad really quickly.
Oh,
So
yeah.
here there's no joint to move around,
No.
so they
And you can
usually stay
tell
good
so
for a
well,
long
like
time.
if anything's even slightly
Yes,
wrong, because you're just
yes.
like, oh,
It-
like,
it's
look
such
at that.
a thin layer of skin, so you don't have all this extra tissue around there
Yeah.
hiding the blown vein and fluid going
Yeah.
into the tissue. So
Yeah.
yeah, it looks
We,
bad. It's not as bad as it looks.
yeah. We had these little, like, kind of like, I don't even know. It was like this dome that you could put on top of a lot of the IVs. And we would like glue little bows or like little bow
Oh, that's a
ties
good
to it
idea.
and be like, there you go. Like, I'm so sorry.
I
Your
haven't
baby
seen
just,
that, but that's
we
not a
were
bad
like, I'm
idea.
so sorry. Or like stickers, like on top of it. We're
Yeah.
like, I'm sorry. Like, good luck, little one. Oh, well, this was super duper helpful. I am so glad
Yeah.
that you agreed to come on and chat, because I feel like like I said, this is not my zone. And I felt like it
Yeah.
needed someone who it was their zone. And I think it was helpful in terms of like, whether you're a new NICU person or just like someone working in the NICU,
Yeah.
to just be aware of, what non-NICU people who are surprised
Yeah.
to be there think. Do you want to tell everyone where they can find you on the internet for all other things?
Yeah,
NICU?
absolutely. So I'm on Instagram at NICU_nurse_Josh. I also have a YouTube channel, but I'll be honest, I don't post a lot of YouTube videos. So mostly on social media, mostly on Instagram, and I'll be ramping up some NICU content here pretty soon. But I also post a lot about jiu-jitsu, Brazilian jiu-jitsu, because I practice that. I've been practicing for 14 years. So that's a big part of my life as well.
Yeah.
So
That's awesome. Well, thank you so much for joining us today. And then everyone stick around because I'm going to drag him back and we'll talk all about the
yes,
NICU and learn
I
everything.
look forward to it.
Yeah. And I'll leave all of his stuff linked down below so you can catch it there. And if you have anything you want to share about your experience with like either working in the NICU or having a little one yourself, like in the NICU, leave them down below, because that's, I think, just the most invaluable thing for, I know with our heart babies, like parents just wanted to know, like, someone else has walked this road before me. And this is not like new to me, like it's new to you, but it's something other people are also experiencing. And even though it feels really isolating because it's shocking, you are not like alone in that. And I think a lot of those parents, they were on all sorts of Facebook groups. I'm sure they have them for the NICU for like
Yeah,
connecting with people and just sharing stories and like hearing about it. So I
absolutely.
very much appreciate you for being here. Thanks for sharing all your
Yeah,
wisdom with us. And
thank you.
we'll see you next time. Bye, guys.
Bye.